My name is Amy Nunn. I'm Executive Director of the Rhode Island Public Health Institute. I am also an Assistant Professor of Public Health and Medicine at Brown University. I hold master's and doctoral degrees from the Harvard School of Public Health, and I've been working on research and programs related to access to essential medicines for the last 15 years, both domestically and overseas. To respond to unmet need for hepatitis C screening, treatment, and curative therapies in our state, last year, in partnership with the Health Department and also with Dr. Lynn Taylor, whom you will hear from next, we developed the Rhode Island Hepatitis C Action Coalition, which is a coalition of about 70 concerned experts, academics, consumers, people living with hepatitis C, and also physicians, to try to bring everyone with any knowledge or interest in addressing this, our nation's hepatitis C crisis, together to develop some innovative solutions. And we've been working together ever since, hand in hand with the Health Department, under the leadership of Dr. Michael Fine and also soon to be Dr. Nicole Alexander, neither of whom could be here today, but who have generously lent their support to this coalition and this broader public health initiative. Our coalition's mission is to advance hepatitis C screening, treatment, and cure in the state of Rhode Island. My testimony is also informed by a large public health program that I run in Philadelphia, Pennsylvania. We've screened over 10,000 people for HIV and hepatitis C during the last 3 years, and that program is run by my colleague, Caitlin Towie, who's here today. And we're now in the process. You may be wondering, why am I so interested in this? Is because we're having a devil of a time trying to cure people there and here of hepatitis C. And so today I want to offer my testimony in support of increased access for curative treatment for hepatitis C therapy in Rhode Island. So before I get into the really controversial issues which are related to costs associated with the drugs for treatment, I want to just give hepatitis C 101. There are several different kinds of hepatitis, A, B, C, D, and so on. A and B there we have vaccinations for A and B, and most people are vaccinated for A and B now. There is no vaccine for hepatitis C. But in recent years, there has been a huge public health response to the hepatitis C epidemic, and a lot of new pharmaceutical products have come to market in the last 6 months that allow us to effectively cure hepatitis C. We've also had a lot of there has been these innovations have been long awaited by a lot of people in public health, and particularly in the infectious disease and GI medical communities, because for the last 30 years we haven't had good treatments. We've been able to cure people with hepatitis, but the drugs have been very toxic. They cause a lot of side effects that can make people really sick, and they're really undesirable in a lot of ways. We are now it's important, before I go on, actually to describe the magnitude of this epidemic. About 3 to 5 million people in the United States are living with hepatitis C. That's just to put this into context. We hear a lot more about HIV in the United States than we do about hepatitis C, but Hep C is actually 5 times more prevalent. There's also a common misperception that this is a disease that only affects homeless people or injection drug users, and it's true that those populations are disproportionately impacted, but the population that's most heavily impacted are actually baby boomers. So I'm looking out in the audience and I'm seeing that we have probably a lot of baby boomers in this audience. That's usually people age 49 to 69, so if you fall into that age category, you are probably at much higher risk for having hepatitis C than people in other age brackets. So think about this. This is your parents. This could be you, your grandmother, and this is something that requires a lot of public health attention. The other thing that's really important to know about hepatitis C, and you'll hear a lot more about this from the clinicians in our coalition who are a lot better poised to tell you about the medical consequences. It's the disease that you can live with for a long time, but can make you feel really, really sick, and can also lead to liver cancer, which can also require liver transplantation. Hepatitis C can also cause jaundice and a whole lot of terrible side effects, depression, fatigue, et cetera, et cetera. But here's the good news, is that we actually have new medications that can cure hepatitis C. Rhode Island has about 16,000 to 20,000 people who have chronic hepatitis C infection, and we now have drugs that we can cure people with very brief regimens. So that means as little as one pill once a day for 8 to 12 weeks. So we are really poised to address this and to actually cure a lot of people that we weren't able to cure for the last 30 or 40 years. The problem is we haven't been doing a lot of screening, and also the cost of these medications has been perceived as really prohibitive. So this has really sounded the alarm bells of a lot of public policymakers, because the cost of these new medications that have very high cure rates. Let me go into the cure rates actually before I talk about costs. These drugs can cure approximately 99% of people living with hepatitis C, so they're highly effective. There are two really novel products. One is made by AbbVie and one is made by Gilead, and it's really important that we actually have two drugs in our toolbox, because that has led to a price war between these two pharmaceutical companies, and we know what happens when there's competition in the marketplace. Prices go down, and that has been a really good thing. However, the drugs are very expensive. I don't want to sugarcoat this. The market value of these products ranges between $30,000 to $90,000 per cure, and this has really shocked policymakers at the federal level and also payers. The real problem, though, is not just the cost of the medication. It's the pent-up demand for people who are awaiting treatment, and also the 75% of people who are chronically infected, both in Rhode Island and around the country, who don't know their status. We haven't been doing a lot of screening, so a lot of people with chronic hepatitis C infection do not know that they are infected. One big problem about the cost of these medications is that there has not been a lot of public transparency about the cost of the medication. There's been a lot of speculation. We've seen a lot of bulk purchase agreements between payers, pharmacy benefit managers, CVS, Anthem, Blue Cross Blue Shield. A lot of companies are signing on to do bulk purchase agreements to try to tamp down the prices of these medications, and that makes a lot of sense. One of the challenges is that this has not been a transparent process. We know that that those companies are getting negotiations, but we don't know what they are. So one thing that public policymakers can do, I think that's important, is to demand transparency about the costs of the medications. I think that these bulk purchase agreements that we're seeing around the country, including in Rhode Island, are really good things, and they're good for public health. It's important to think through the business model of this challenge. What has happened to date is that we have had a business model that is a high margin, low volume model. Industry needs to recoup its investment. That makes sense. Whenever we make an investment, we want to make sure that we get back the money that we've invested in it. So the pharmaceutical industry has invested a lot in bringing these drugs to market. The problem is that we haven't done a lot of screening, and so there are a lot of people out there who don't know that they're infected. So what we really need to do is ramp up screening so that we move from a high margin, low volume model to a high volume, low margin model. Think about what the VA does with their pharmaceuticals. They bulk purchase a lot of drugs, and that's good for consumers and it's good for public health. We need to be thinking a lot more about bulk purchase agreements, but these things need to be done in a transparent fashion so that patients can reap the benefits of all the medications that have been brought to market. What's currently happening, and that's a big problem, both in Rhode Island and other places, is that there has been a big effort to tamp down access to medications. That's precisely what we shouldn't be doing. What we need to be doing is treating a lot more people. The reason that this is happening is because there's great fear about the costs associated with scaling up treatment for these life-saving medications. One big problem, though, is that the way that you all may or may not know that it's actually illegal to deny people treatment or medications based on the cost. And so what Medicaid and other payers around the country are doing is putting in place very rigid prior authorization requirements, a lot of which have not been grounded in scientific evidence. They've also reserved these medications and treatment of these using these medications for some of the sickest patients. I want to remind you all, though, that the scientific evidence base demonstrates that this is not what we should be doing. We should be broadening access to these medications and really bringing the private sector and the public sector together in a happy middle ground in some kind of bulk purchase agreement to promote more widespread access, both in Rhode Island and around the country. A lot of other states are doing this. It's sometimes important to think about what our peers are doing. So I just want to give a brief overview of what some of the other states around the country and our neighbors are doing. New York's Medicaid program has agreed to treat all people living with hepatitis C. Let me repeat that. New York is going to treat everyone. Our policy in Rhode Island right now, at least under the Medicaid program, is to reserve treatment who have very advanced liver disease. Other states around us are opening up access, and I think it's something that we should really look at and consider very carefully in Rhode Island. Massachusetts, Maine, and New Hampshire have also broadened access, and they also allow providers to choose the medications that they think are the most suitable for all of their patients. I think this is really important because what's happening in a lot of these bulk purchase agreements is that industry is asking for exclusivity or putting only one drug on formulary. That's bad for public health, and it's bad for patients. It's bad for the practice of medicine. The physicians that are going to follow me, I imagine, are going to talk a little bit more about this. But what we want to do is actually expand access and not limit the treatment options that are available. So when we're thinking about bulk purchase agreements, we may actually be locking ourselves in to policies that aren't good for public health if we have exclusivity agreements with pharmaceutical companies for only one product. And that's really important because the products, while they have similar cure rates, are not therapeutically interchangeable. There are some small differences between the two products that are available. One of them has a lower pill burden, one pill once a day, and it also doesn't require other drugs to be taken with it that have other side effects. And that's really important. The drug that has the higher pill burden is coming in at a lower price, both in Rhode Island and around the country, and having access to that drug would be a huge advance for public health. So I don't want to diminish that. If that ends up being the only drug that's on formulary, I will be so pleased that we have made a commitment to expand access to treatment in this state. However, it's really important that providers also have access to the other medications that are made by the other company so that they can provide the drug that is most suitable for their patients. And I'm sure all the other clinicians are probably going to talk about this as well. The other thing I want to talk about is to dispel some of the myths about the costs associated with this. Legislators from around the country have looked at the price tag of these medications with great alarm, but all of the recent data coming out shows us that it is more cost effective to treat people now than to wait until people are really, really sick. I'm very happy to provide all of you with the peer-reviewed science about this. There have been some really innovative studies published just this week that prove that treating people early in the course of their infection is important, and it's also cost effective. And that's because it saves us the costs down the line that we would that patients would experience as a result of advanced liver disease. So it's pay now or pay later. The other thing that's really important to note is that if we don't treat people, these people are, what do the health plans want us to do? They want people to age into Medicare so that they don't have to do this, that they don't have to assume the payment. That's the game that's happening right now between payers and industry. And it's bad public health and it's bad for patients. And ultimately, the taxpayer is going to have to assume the burden anyway, whether or not people are paid, whether or not people are treated on Medicaid now or they age into Medicare. I would argue that it's better for public health for us to expand access and do what some of the neighboring states around us have done and to take the plunge. I also think that I want to remind everyone of some lessons from history. 15 years ago, our foreign policy in the United States was that we wouldn't provide drugs for HIV treatment to people living overseas. We institutionalized that policy to let people die of AIDS. And what happened? A very vibrant social movement emerged and said, this is a human rights violation and we can't do that. And over time, as the private sector worked with the public sector and with foreign aid and donors, prices came down as more people received treatment. So what happened? The data show us that we went from $10,000 per patient per year for HIV treatment to now $62 per patient per year. But we have to have an initial commitment to do this, and we should be doing this for hepatitis C medications in this state as well. The other thing is there's this big fear that if we treat people now, there's going to be an apocalypse and this is going to gobble up the entire Medicaid budget. Here's the truth of what is really going to happen. A lot of physicians around the state and around the country have been warehousing or harboring patients. What does that mean? They have been waiting for patients who could wait to be treated for these drugs to come to market. And now we have these two fantastic products that can cure people of hepatitis C, and we can't get them drug. It's a huge problem. But it's not that all 20,000 people in Rhode Island are going to present for treatment at the exact same time. A few hundred or maybe 1,000 people would probably be ready for treatment tomorrow, and the rest don't even know they're infected. So this probably won't be as pricey as a lot of people are as concerned about. And one thing we're working on is trying to work with providers from around the state to get the actual number of patients that are on Medicaid that are treatment eligible so that we can get a little bit closer to having that estimate and back into some realistic cost estimates. But I think to assume that this is going to gobble up the whole Medicaid budget is probably unrealistic. And I want to mention that because I am sensitive to the current budget crisis. And I know that a lot of things are on the chopping block for Medicaid, but I think that this is something that deserves a line item in special treatment examination. The other thing I want to remind you for the legislators in the room is that baby boomers are most likely to vote. So these could be your constituents that you're actually helping out. So where are we from here? Where do we go from here? I just want to leave you all with some important public policy recommendations. One is that we need more bulk purchase agreements, and we need a transparent process about the way that drugs get onto formulary and also the price that our state is paying for these medications. And that's not unique to Rhode Island, that's around the country. I also want to remind you that we should not be rationing care based on the cost of the medication. That is not legal. We should really embrace the peer-reviewed science around this and adopt policies that are meant to expand access and expand access to drugs that we know that we can cure people. I want to just close by saying we're really at a critical juncture in history. This is sound public policy, and treating people with hepatitis C is a cost-effective intervention that will ultimately culminate in downstream cost savings for the Medicaid program and for all of our other public health programs. Lastly, I want to just remind you that I think it's really important that we let physicians decide what are the best treatments for their patients rather than restricting access to medications on formularies. I'm all for bulk purchasing. I'm all for reserving some medications for select therapeutic use, but those decisions should be made by providers and not by those of us who may not have a nuanced understanding of what's best for our patients. Thank you.
I'm going to reserve questions till we have two other speakers, Dr. Epstein and Dr. Taylor. I think some of the answers to some people's questions might be with those two presentations. I would ask Dr. Epstein to speak next. He's signed up next. But I will ask both Dr. Epstein and Dr. Taylor what we do to anybody who testifies on anything here on the same overall subject. Is you don't have to be redundant to what Dr. Nunn said, but if you could add additional comments, it would be preferable to that.
I'll see what I can do.
Okay,
well,
great.
Dr. Nunn is Southern and charming.
Yeah.
and that makes it better for her to be the open, because frankly, I'm a kid from the Bronx. So let's, talk about where I'm at. I started treating hepatitis C in 1990. And when I did, I remember writing letters saying I was going to use these injectable drugs, and my dear friend Peter Holman over at Blue Cross, would stop me in the parking lot and say, "Oh, Alan, this isn't the National Institute of Health." Well, he was kind of right, because I was curing about 1 in 20 patients, and then it evolved to about 4 out of 10 patients that I could cure, 4, 5, 6. Now, if I see a patient and there are no other barriers, I got a higher than 95% chance that I'm going to make that patient well. That's a pretty simple scenario. So what have we got? Well, what we got is a reason to screen more people. Maybe you have half a Fenway Park worth of patients in Rhode Island that need treatment. That's everyone from in the Corrections Institute to stockbrokers who used injection drugs at a Grateful Dead concert, 30 years ago when they were in college. It's a chronic virus, and it's like Neil Young said, rust never sleeps. Well, rust never sleeps. You don't get terribly ill and you're not in the ICU with this until you have advanced disease. The problem is the spectrum of going from mild disease to moderate to disease to severe disease. No one has a complete crystal ball. I'll give you one scenario. 53-year-old woman who I'm taking care of lost her 8-year-old daughter to illness when she was 8 years old. Dabbled in intravenous drugs, got Hep C. Is my patient back in nursing? After rehab, great. Monotherapy, not an HIV patient, just straight ahead to Hep C. I work her up, I stage her. She has a biopsy that's moderately advanced. Cirrhosis may be a 4, she's sitting between a 2 and 3. She just got denied treatment because she's not sick enough yet. Okay, so, I'm going to have to tell her in the office that her health plan decided she's just not sick enough yet. And if you want to mirror that, I can tell you that right now in my own practice, I probably have between 30 and 50 patients on treatment. I have a couple of hundred that are warehoused away, and in each and every step, there is a prior authorization to try to get them drug. Okay, I understand that you don't want these drugs used willy-nilly, so that if you're careless, you're going to be wasting $30, $50, $70, $90,000 at a clip. At the same time, I'm an experienced treater, and my physician assistant is spending about a third of her time doing paperwork for the pharmaceutical industry and for the insurance companies, whether they be a for-profit insurer or a not-for-profit insurer. All the players are the same in terms of the burden of paperwork for people like myself. So, I've been in this long enough, in 25 years. I can sit at the perch from the Medical Advisory Committee of the American Liver Foundation and say, this is the best of times. You come to see me, you're sick, if you have the right insurance and I can play it enough, and if you're sick enough, I'm going to get you treated and get you well. Where are the bottlenecks? The bottlenecks are in screening. Not everyone knows that they have it. So the CDC, the U.S. Public Health Service Task Force, virtually everyone wants all the baby boomers screened. It's a quality indicator in every medical chart right now. Get screened. Get screened, find out you have the virus. You'd like to say get screened, get treated, get cured. Get screened, get treated, get cured. However, whatever the products are that are out there, and there are 2 good ones and others coming, we have all oral therapy. So we went from having maybe a total of 7% of the Hep C population treated to date, and 93 to 95% of it untreated, to the ability to pretty easily treat everyone. Now, I live in the real world, and in a perfect world, I would be driving my Tesla home. But I'm not. And why am I not? Because there's not a $40,000 Tesla out there yet for this gastroenterologist to buy. There's only a $90,000 one. When that break point is low enough, it makes sense. I look at the pharmacy budgets in the United States, and I say in the last half year, they're up 13%. Something like 9 of that 13% is thanks to my hepatitis C drugs that are in that mix. So there has to be a lot of bulk buying. There has to be a lot of back room manipulating to get these products down, and so that the VA system can do what for its patients, so that the big insurers like United have to get off the pot and make their decisions. I think most of us who are treaters can work with any of the products. Some are simpler than others. Do we all like the concept of one pill once a day? Yeah. Can I work with simple blister pack cards and cure people? Yeah. When I lectured on this topic 2 years ago to the medical staff at Roger Williams, I said, in 2016, internists will treat hepatitis C. And they laughed and were like, yeah, you're nuts. And I said, no, if these drugs come aboard, any decent family doctor, any smart nurse practitioner can treat and cure patients. So you can eliminate the subspecialty bottleneck. Right now, I was in one of our affiliated offices last week, and I said to 5 very smart internists there in Johnston, I said to Drs. Ferry and Savaretti, and Dr. Ferry's written a lot of general medical textbooks, and I said, you guys can do this. Draw blood, treat, draw blood at the end of therapy. What's easier than that, really? And he said, we'll do it when we don't have to do the paperwork that your office is currently doing. So the bottleneck is primarily prior authorization. And I do understand that, at least right now, you want these drugs in, quote, responsible hands. And maybe I'm a responsible user of these drugs. But plain fact, if you're going to have a public health impact, then anyone can do this. You do not have to be a rocket scientist to treat hepatitis C. You have to be a rocket scientist to take care of really advanced liver disease patients. And while we sit and watch the rust on the car accumulate and accumulate, I will have more of those patients. More patients who need liver transplants, more patients who develop liver cancer, more patients who are chronically ill. It's a heartbreaker. It's a heartbreaker to have a patient in your office and say, I could cure you, but Company X decided that at this time you are not sick enough. Go home and get a little sicker. Really? When you do that, it makes you want to holler and throw up both your hands. It has to make you want to do that. So we're close. It is the best of times and worst of times. Come to my office and you'll get to see people who are clapping their hands and hugging my physician assistant. She got more presents this Christmas than, than anybody. She was going home and I said, it doesn't look right. You're like leaving with boxes and candy and wine and everything else. Right. At the same time, you're not behind the closed door when people are crying. People who I tell them you're not sick enough yet, that isn't right. That isn't right from a health insurer that is a for-profit insurer that paid its CEO $180 million last year. That CEO ought to come to my office, yes, United Health Plan. Sorry, I didn't mean to mention names. That doesn't make the not-for-profit insurer Blue Cross, who won't let my patients use the $2,000 rebate card so that they could do the copay portion, doesn't make them better. It makes them the same. It is a poker game, and I'm at it. I'm tired of it after 25 years. I went gray doing this. I had 5% success rates. Yeah, I did. I came here with a full dark head of hair. Don't laugh. Really, I did. Right? I went gray doing it, but I'm where I need to be. There will be even better drugs. It will be faster. But for right now, every day, it's a great day. Someone got cured. If I was lucky enough to game them through the pinball machine of treatment. It's a horrible day, a horrible, horrible day. To spend one day in my office, if you're a medical student, I had a BU medical student in my office who started crying with the patient when she said, I can't believe what you just had to tell this patient. It was a different patient who I had to say, not sick enough yet. Not sick enough yet. I'm sick of those words. And You know, it's here for us to use. If any of you or your friends or family members came to me, you'd want to be treated, and I'd want to say, hey, I have a 97% chance, 99% chance of making you better if you're sick enough. Tough. Have a great afternoon.
Thank you. Finally, Dr. Lynn Taylor.
So thank you for the opportunity to speak with you today. So as not to be redundant, I will adjust a little bit what I was going to speak to, but you should be very glad I didn't go first because I'm a kid from Brooklyn. I'm a lot worse than the Bronx. Although I'm a Rhode Islander, I've been here since 1997 and been caring for patients in Rhode Island with HIV, AIDS, hepatitis C, addiction, and I'm also a primary care physician here since 1997. And I work locally and with our colleagues we heard from today, but I also work nationally with the CDC. I put in a $16 million grant with the CDC 2 weeks ago to get more resources for research. I work with the World Health Organization, and I'm one of the only American physicians going back to Geneva this June to help the World Health Organization update its Hep C treatment guidelines. So I do as much as I can to keep up with a very rapidly evolving field and bring it back to Rhode Islanders. I'm not from a medical family. I'm from people in public service and school teachers and electricians, and the National Health Service Corps, the federal government funded me to go to med school. In return, I made a commitment to work for underserved populations, which I will always do. That's Hep C. Hep C is the poster child for marginalized, disadvantaged patient populations. It doesn't mean that 1 in 30 baby boomers, 1 in 30 of us in the room does not have Hep C, but it means this epidemic disproportionately impacts the most socioeconomically disadvantaged Rhode Islanders and Americans, the most educationally disadvantaged, the most underinsured. This is a big problem for Medicaid. Medicaid, and as you heard from Dr. Nunn, and Medicare are going to be paying for hepatitis C. And what I'm concerned about is that decisions may be made in the next days, weeks, months, years that may sharpen the healthcare disparities that already exist. And we may have a have and have-nots epidemic. We don't have that. I don't have that as an HIV doc because we have federal funding, Ryan White funding, which means that I can provide the same standard of care to people who are economically privileged and people who are economically not. We don't have that federal funding yet for Hep C. We're working on it. We have many people in this room and we need help. I'm not saying Rhode Island can do it. But that's where we're heading if we don't want a two-tiered system. I take care of people at the hepatitis C program at Kodak, which is Rhode Island's only nonprofit methadone maintenance program started by Dr. Pelagian. He's a pioneer in Hep C work. I work with AIDS Care Ocean State, and I take care of HIV-infected, underinsured patients at Miriam. But I just want to, before I go into a few things, I know it's very late, just go back to why are we here today? Why are you here so late? Why are we all here so late now? This is, as you've heard already, I just want to highlight a few things. We are in a crisis point right now. We do not have the luxury of waiting 6 months, a year, 5 years for medication prices to go down. Rhode Island is going to lose a ton of money, even if you don't care about the human suffering that you've heard about already. You are going to lose a ton of money, the taxpayers, the State House is going to lose a ton of money, because what's inevitable is that Hep C infections, for the most part, were acquired in the 60s, the 70s, the 80s, the 90s, before we knew that this virus existed. Most people have no idea how they got it or when they got it. 3 out of 4 Rhode Islanders has no idea she or he is infected unless we get tested. We'll have no idea because we don't feel anything when we get infected. But the enemy of Hep C is time. So all of us infected in the 60s, the 70s, the 80s, and 90s by no fault of our own, maybe we got a blood transfusion, we got an injection, we have no idea what happened. Now the liver is getting more and more and more and more and more scarred. And we're at the crisis point in Rhode Island, the United States, where the proportion of people whose liver is fully scarred is peaking. The proportion of people who are going to develop liver cancer in the next 1, 3, 5, 10 years in Rhode Island is peaking. Liver cancer is a death sentence. You're dead in 6 to 9 months. The proportion of Rhode Islanders needing liver transplant, and you can bet I'm referring my patient to liver transplant, is going to be peaking. And that's $500,000 just for the operation. That's Massachusetts, Connecticut. We don't have liver transplant here. Excuse me? How much for the operation? $500,000. And then you have a lifetime of care. I'm sorry about the bang in the microphone. And medications to suppress the immune system so that you won't reject the liver. Liver failure. We have a very high proportion of patients now heading towards liver failure. That's about $250,000 for the last year of life for somebody with liver failure. So we know if we don't intervene now, you're going to be paying a lot of money. The question is, do you want to spend a ton of money on all these patients in 40s, 50s, 60s, leaving the workforce, not being able to take care of their children and grandchildren, going into our emergency rooms, having no idea what's going on, and having projectile bleeding, vomiting, which just happened. I just got called to see someone. She didn't even know she had hepatitis C. She bled out in front of her family. We are going to pay. So what we can do is be more proactive and invest the resources that we do have in keeping people from that liver failure, because you don't feel anything when you have the scarring. But what we're going to be seeing right now, we're seeing it every day without the treatment and the intervention, is these people who have scarring in the liver slowly get swollen ankles, swollen calves, swollen thighs. I'm sorry, men, you're going to have swollen scrotum so big it's a basketball between your legs. Skin is going to chafe off. Your belly's going to be as big as though you were 10 months pregnant. You're going to fill up with fluid. This is what happens. The lungs get full of fluid. You turn yellow. Your balance goes off. Your brain gets bathed with chemicals that your liver's not filtering, and you can bleed out, have very terrible bleeds. This is a very bad way to die. It's an agonizing way to die. And it's very painful for us as physicians to see that we have these brand new tools that are so safe and so effective and can prevent all of these downstream horrific effects, taking people out in their 40s, their 50s, their 60s, our breadwinners, our taxpayers. We could intervene right now and prevent all this. To stand by and say, we can't do it, we can't do it, we can only treat a tiny percentage of people, we're going to let this happen to everyone else, it's very hard to see. And we can intervene and do a lot of things to prevent this from happening. Because, again, you're going to be spending a lot of money. It's just a question of if we spend it the right way or we don't spend it the right way. And just to follow up on what you heard about the medications, the reason we're so excited right now is that the old treatments were injections for a year. They caused suicidality, homicidality, very, very toxic, cured very few people. These new drugs are a cakewalk. A few weeks, people do great, and we're not hospitalizing people and killing people with our medications. So just a few more things. When Dr. Epstein was saying we can't treat people unless they're sick enough, we are gambling with people's lives. When we tell people with cancer, you have a little bit of breast cancer, just in one breast, but we can't use Medicaid dollars until it gets really bad. We have to wait till it's really bad, and it's in your bones, and it's in both breasts and in your brain. You're definitely going to die. The things that we're saying and we're hearing about Hep C do not apply to other diseases. We don't say to diabetics, sorry, Medicaid won't pay for your insulin until you're really, really far gone and you're definitely going to die. And we might miss the opportunity. There is a point of no return with Hep C. If you wait till your belly's swollen and you start bleeding, you get liver cancer, it's too late. It's too late to intervene and stop all this liver failure and all these horrific complications. We have to cure before that happens. So the waiting till you're really sick is a gamble. You're gambling with people's lives. And we've seen it happen. I've seen in the last year patients with scarring, I can't get their meds. They get liver cancer before my eyes. They die in front of my eyes. They die in front of their children's eyes. And it's agonizing because these are 50-year-old people and it was preventable. So as an HIV doc, I've been working in the HIV epidemic for 33 years. Many of the lessons that we've learned are applicable here. Of course, they're not identical epidemics, but there's some comparisons to make. And I think you've heard today that proactive care we've learned saves money. Again, forget the human suffering. We know with HIV and AIDS, early diagnosis, early care saves a lot of money, so you don't have tons of people in the hospital with end-stage AIDS. And we have, again, as you heard from Dr. Nunn, study after study after study showing evidence-based scientific proof that it's cost-effective to treat people early on. Someone also said, I'd be happy, if we had this new pill that maybe is a little cheaper. I would not be happy at all, because we've learned from the HIV epidemic, or I look at my diabetics or high blood pressure patients, you are all the same, but we're all different. If you all have high blood pressure, you can't have the same exact pill. There are nuances to your health situation. How's your heart? How's your kidneys? We need patients and doctors to have choice. If right now I heard that Medicaid is just going to have one HIV medication, people would be storming the State House. I couldn't do that for my HIV-infected patients. We need to look with Hep C at the individual patient circumstances. How are the kidneys? How's the heart? How bad is the liver? There are a lot of things we have to look at. Some of the drug-drug interactions between some of the Hep C meds and other meds are deadly. And most of my HIV-infected patients can't take the cheaper pill, the pill that's going to come out cheaper, because the drug-drug interactions are so dangerous they can completely mess up the HIV regimen and mean that we're going to be paying for more and more and more expensive HIV medications. So we have to be very careful and make sure that physicians and patients have choice. I want to just tell you, because you're going to be hearing this, I think Medicaid is going to be, we're in a tough situation. We, as you heard from Dr. Nunn, we have one pill once a day for 12 weeks. That cures most people most of the time. Most people can do it. It's very safe. Here's the alternative that's coming out, and they're going to try to get Medicaid, I think, to exclusively use their drug. Instead of 12 weeks, for most of my patients who have type 1, which is a type of Hep C with scarring, there's different types of Hep C, different pills for different types, we go from 12 weeks to 24 weeks. So not one pill once a day for 12 weeks. Now you go into 6 months. Instead of one pill once a day, it's 9 pills a day. 5 in the morning, 4 in the afternoon or evening, 30 minutes after you eat. It includes a med that we've used for HIV for years, ritonavir, that we've been trying to throw in the garbage that causes nausea, vomiting, and abdominal pain. No one's going to be able to take ritonavir for 6 months with this regimen easily. This regimen, the one that may come out cheaper, also contains a pill called ribavirin, which is very toxic. It's like a pin, pops your red blood cells. Everybody's red blood cells get popped. Everybody loses blood. It's like if I just right now came and took a couple of units of blood out of you. If you have underlying heart disease, you'll have a heart attack. People die in ribavirin. If you have underlying high blood pressure, you could have a stroke. People have had a stroke on this medication. If you have underlying lung disease, you could stop breathing. This is a dangerous medication that has to be very closely monitored, which brings up more cost. This pill is also very dangerous to a developing fetus. This is called teratogenicity. So again, the pill that you may be presented with, that Medicaid may be presented with and sounds better, can cause damage to a developing fetus so severe that we recommend termination. The standard of care is to tell them, if you get pregnant on ribavirin, you should definitely have an abortion, and there's a national registry of the birth defects from this medication. And the medication can cause birth defects when a man takes it and his sexual partner is pregnant or could be pregnant. And the pill lasts in your body for 9 months. So you can't get pregnant for 9 months after you go off it. So we don't have two equivalent regimens. And Medicaid and others may be presented with two choices: one pill once a day that's safe for 12 weeks versus 24 weeks of a lot of pills that is not safe and effective, and patients are going to have trouble taking all those pills with toxicity and drug interactions and all these other problems. And the metric you have to look at is cost per cure. It's not that drug A looks like the pill's more expensive. It's $200 a day versus $1,000 a day. The metric we have to use is cost per cure. How much are you paying for cure? And what the evidence shows is that the 6 months, all the pills, all the problems lead to a very low percentage, a lower percentage of people getting cured, because not that many people can do that for 6 months. And you have to take all those pills every day to be cured. A lot more people can take one pill once a day safely. So when you're comparing the regimens, when Medicaid, and I'm hearing, and I don't know if this is true, that they're going to make a deal for this inferior medication, you're not necessarily saving money at all. So the metric has to be, what is the cost per cure? You're wasting a ton of money if patients take all these drugs and they don't get cured. The only benefit in reducing the chance of liver cancer, liver failure, saving money, hospitalizations, end-stage liver disease, is if you cure people. Just taking the pills and not getting cured doesn't help anyone, but you spent a ton of money. So the holy grail is one pill once a day, and we have it. And all the new pills coming out are going for that one pill once a day. So we have to be sure, as Dr. Nunn said, that whatever negotiations there are in terms of payers and patients and money are transparent, because a lot of these pharmacy programs are making a lot of money, and they're going to make more profit, and they're going to not allow a free market where new drugs can come in and underbid, because we don't really know what the wholesale costs are. We don't know where the money's going. The patients' rebates aren't being factored in. So as much as there can be transparency, we should have, again, and I think this is where we could get some help, we don't want a situation where patients and doctors are restricted and we're wasting money on meds that are not going to cure people and be very toxic. So I did bring, in closing, I'll just say I did bring copies of some recently published articles that go through the cost effectiveness issue and some of the problems with the pharmacies and the negotiation, and some background reading on Hep C. I really appreciate your attention and your time today. Thanks.
Thank you to all three of you. I'll start off with a question for whoever might have the answer. Legislators and within the State House, especially within a few days of the budget being presented, are always interested in the medical information we got here, but they're also interested in presenting, often based on financial considerations to the state. I know there's a large expense to the state. Is within the ACI budget and Rhode Island Medicaid. Any of you have those numbers?
I requested the numbers from Rhode Island Medicaid, but and I have them, but I'm not sure how the numbers were developed, and whether or not they were based on. What I would ask is whether those numbers are based on the cost of treating all 20,000 people, which I would argue is not a good way to think about this, because those people will not emerge immediately. It'll take 20 years to diagnose all those people.
With current treatments, the expense currently for Rhode Island, either ACI or Medicaid is?
I don't know the ACI, although I don't know what the projections are for either. But what I will say is that sometimes we think about incarceration in the wrong way. Sometimes when people are incarcerated, it really presents a public health opportunity.
Yeah.
We lock up people because they have addiction. Half the people that are at the ACI and in correctional institutes around the country are there because they've been locked up for engaging in behavior related to substance use. Those are the very people who we should be prioritizing treating, because they may be engaged in substance use upon release. It's a real public health opportunity to cure the people who are most likely to transmit hepatitis C. So rather than thinking about it as a burden, I would actually say that it's a huge public health opportunity. And
as I understand it, it's being looked at in that way by both the ACI and the EOHS administration.
Right. I think that's a very limited framework that we should really think about how to broaden access at the ACI. I think that should be a public health priority, but also in the community.
And one of the numbers I heard, and we'll try to get verified on this, is that the combined budget between ACI, because they don't use Medicaid dollars, they use their own budget for this type of treatment. Between Medicaid and ACI, it's about a $30 million figure in the current year.
Those are the numbers that I saw in the report as well, but I'm not sure how they were developed.
And so when just to give a context to it, and we'll verify those numbers as we move forward with any recommendations throughout the season. But has there also been any
I guess, can I just add one thing? I think it doesn't have to be all or nothing.
Right.
Let's at least treat more people than we're treating today, and not be scared away by these the numbers. If we can treat at least some people today, like the 1,000 people that are warehoused, we'd be making a huge public health. I think it's a huge public health opportunity.
Has there been any research on current Medicare expenses to treat liver failure and transplant currently, and the impact of treating and what it would have, what kind of impact it might have on Medicare versus Medicaid? And is there any discussion with Medicare in order to diminish a financial burden within the Medicare budget? Has there been any discussion with Medicaid or private insurers to kind of even subsidize treatment to prevent expense in Medicare budget?
I don't have the answer to that question, but I'm very happy to look into it. And I also know that this is an issue that was discussed on the Hill yesterday in Washington. This is a federal issue as well. So.
Yeah, when it's a Medicare issue, it's a federal issue. When it's anything else, it's a state issue. So.
Yeah, I think from personal experience, Medicare right now for me is the easiest. The drugs are all approved, and it's not where most of the patients are nested. Right now, the patients are primarily headed towards,
because it's a fraction.
They're headed, right. They're the leading edge of the right. So those are the people.
The 250,000 number and the $500,000 number for failure and transplant makes the treatment number very small. And so there would seem to be room to discuss budgetary concerns on both sides of the payers. I don't want to monopolize this. So,
Are these on?
Yeah, they're on. Well, now you just turned it off.
Oh,
Yeah.
okay.
Yeah.
First, I'd like to thank Chairman Miller for inviting us here tonight. Thank you very much. And thank Dr. Noon, Epstein, and Dr. Taylor. Thank you very much. Great testimony. You stated that in Rhode Island we have 15 or 16,000 people that have Hep C, and that 3 out of 4 Rhode Islanders do not realize that they have hepatitis C. When we have many of these individuals are also taking statin drugs like Lipitor, where their doctors order routine liver screenings. Does it show up at all in any of those screenings?
Routine liver tests are not needed for statins really anymore because statins are safe for the liver. So when doctors are ordering that, they're kind of showing their stripes as something that no longer needs worry. Liver tests themselves are often elevated because people are, like myself, are overweight. So my liver tests might be like twofold elevated. It's not, I know I'm Hep C negative, but I also know that you can't use just liver function testing. So the push across the board is just screen the 1964 plus 46 to 64 cohort, and to at least get that. Talk to patients who are at risk from IV drug use, and things like that, and you can get a pretty good handle on this. So most internists who use electronic medical records now are getting something saying, hey, this person is 56 years old, he ought to be screened for hepatitis C, and one off that. So yeah, it's something that needs an $8 blood test.
Oh, it's $8.
It's $8.
That's my question. Thank you.
A standard Hep C blood test, $8.
So I would just add to that the U.S. Preventive Service Health Task Force said that it is cost-effective and beneficial to screen the birth cohort, the baby boomers, for Hep C. You don't have to ask anybody what they did, what their risk factor was, if you ever snort drugs, you ever inject drugs. Just if you're born then, you're at high risk, get tested. So how do we do this at a systems level? You can't have each patient have to know and each doctor have to know. So what do? The CDC says get all of your electronic medical record systems to have a pop-up. When we were kids, you go to the doctor's office, there was a chart. Now it's not a paper chart, everything's going to computers. So we can exploit this technology, which has been done in many places, many states, and have a pop-up reminder, because every medical record has someone's date of birth. If you're born between this year and this year, is a pop-up, hey doc, hey patient, get screened for Hep C. So this has been found to work very well. And so what we're doing in Rhode Island is implementing this, and I think a reasonable goal, given our health department's great successes with HIV, we should be the first state in the country to have our entire state covered by electronic medical records and a prompt for screening the baby boomers. And April 1, Lifespan, which is the largest health provider in Rhode Island, doesn't cover everybody, but it's the largest health provider, is going live with a new computer system called Epic. And on that day, it's being built into the system, starting April 1, we'll be able to, for anyone who is a primary care physician within that health network, there will be an automatic reminder for the baby boomers. And we'll at least, we're working on this effort collaboratively, we'll at least be able to start doing this, we'll get a better sense of which practices, which locations, et cetera, and then our goal is to report back on this, work with the health department, and get the whole state covered. So at least we could be at the forefront in terms of getting our population screened. But it has to be, I think, very much systematic.
Absolutely. My friend, Dr. Afdal at Beth Israel Deaconess, did this throughout the care group system. That's, a comparable size system to the Lifespan system, and they had unbelievably great success with it the last 18 months.
We're using the Beth Israel model.
Yeah.
All the Hep C docs around the country work together.
Are using that prompt.
I know that from our certificate of need hearings that in Rhode Island we still require for new providers in Rhode Island a office physically and a file cabinet for medical records. So I would recommend that your professional organizations and other medical advocates first lobby the Department of Health to change those outdated regulations. I know it's a big issue with people that want to come into the state and provide medical services. My last and final question is there an ethical way with large Hep C positive populations to limit who receives it? Is there a prioritized way that you would think is ethical if the state of Rhode Island just cannot afford to treat everyone? How do you establish that are priorities in a way that it's ethical with large populations like our prison population?
I mean, I think that's why everyone has defaulted towards, playing lifeboat, sickest first. And that is what we do. And then there's a second level of questionable ethics, which is compliance. They want it in treaters' hands who are making sure that when we give you $30,000 or $50,000 worth of drug, that patient has a higher than 95% chance of taking all the drug and getting cured. If you've got that I have to replicate in my office what I'm telling you here. If I tell you we can cure 97, 99% of people, and my office is only curing 80% of people, I'm doing a sucky job and wasting millions of dollars. Right? That's pretty easy to do with this. So right now, some of the throttle, I understand it's costly. You'd like experienced people using it, but is it truly ethical to play that game of you're not sick enough, eat? That's a tough one, and everyone who's in that gray zone, which is pretty sick but not sick enough, that's tough for me. That's tough across the board, and I can't split that.
These are old medical questions. There's a lot that's published about distributive justice. What do you do with any epidemic when a breakthrough medication comes in and an epidemic's peaking? This happened with tuberculosis. This happened with other things. There's been a lot that's written in the ethics medical community to guide us. We shouldn't just be making it up. And the ethicists say, when we look at the evidence, it shouldn't be first come, first serve, or who knows who, or who's knocking on this door, or who's best friends with this guy.
Thank you. Representative Handy?
By scarring, we have to do the sickest first.
I'd say one more thing, one more sentence, which is the cheaper drugs that may be more pills are not necessarily more complicated for the non-HIV population. So Lynn has a special population, but for treaters like me who've used injectable drugs for a year and are geared up to provide a very strong underpinning, that's still pretty damn easy. So just bring it on at whatever price. The more we treat, the more we're going to cure. We're going to do better. We can do great.
Thank you.
So I want to echo what Chairman McNamara said. I do appreciate the work that you guys do. I'm a big fan of AIDS Care Ocean State and a big fan of a lot of the pieces, and I do understand a lot of the comorbidity issues you're talking about along the way. And actually, that was one of the questions that maybe you don't have ready data on, but you talked about the sort of explicit, liver issues along the way, but I got to think that once symptoms start popping up, there's a lot of comorbidity issues with somebody with diabetes or other health issues. You're talking about the meds with somebody with, that was like just virtually every single geriatric condition I could think of would be in danger a patient under the less expensive med. But I did also, I know what Senator Miller, Chairman Miller had said too about that $30 million number. That's just 1,000 patients. It's $30 million at the low end of that price range. So I think we need to have a sense of perspective on it, but I think you guys also bring up a very strong case that the prevention benefit along the way. So I just want to get all the questions out once so you guys can then respond to them. One I was curious about was is there a risk of reinfection after somebody's been through a treatment, and also the benefit, say, to preventing further transmission by treating somebody, that kind of thing. I'd be curious about that. Also, just I think you touched on it, but the idea of either interstate agreements to compacts to drive down the price along the way, I think would be extremely beneficial. And then the last piece, you talked about the grant that you were talking about along the way. I know Rhode Island is underutilized, in my opinion, in terms of being used as a great test place because of our size, our density, our demographic mix. And I would urge everyone, not just people that are up there, to pursue opportunities there. I think there are ways to potentially at least get the treatment access points and the delivery systems paid for by grants. We might not be able to get entire, all the meds paid for, but I think if we can get that would make a big difference along the way. So again, the main questions I think are comorbidity costs and reinfection transmission questions.
So you can get reinfected with Hep C right after cure. You can get reinfected again and again and again, just like syphilis and a cold and lots of other things. But the majority of people with Hep C don't have the ongoing risk factors anymore. And even when we do have the ongoing risk factors of injecting or snorting drugs, it's 5% a year. It's low rates of reinfection. There's probably something immunologically, biologically going on. The reinfection rates are low. And it's important to know about, we have to work with patients who might be at risk to reduce their risk of getting reinfected, but we can't withhold treatment from an entire subpopulation because 5% could get reinfected.
I was just trying to see if it had a vaccination kind of an effect or something.
We
like
don't
that.
have
A vaccine will come, no, but vaccines...
No, I mean,
most
of having had the disease.
Better than
I mean,
that,
yeah.
if people have mathematically modeled this to say if everyone starts treating and then the treatment grows and grows, you can draw the curve where this disappears in 2026. So that's only 11 years away if we all start doing what
Because of the transmission,
it's over in 2026.
because of the transmission reduction.
Right.
There is, again, a lot of literature we're happy to provide you about treatment as prevention. You intentionally treat
Absolutely.
transmitters so that the infectivity of the transmitting pool goes down. If no one has Hep C, you can't pass it around.
And in response to your question about the bulk purchase consortium, so there is a consortium, I think it's 27 states around the country, of which Rhode Island is a member. I think that's a great thing. Now, the deal isn't the same for every single state, though. That goes through the PBM Magellan. And I'm unclear as to how that works. The prices are not, to my knowledge, publicly available or haven't been released, and I think that is important for public conversation. The other thing is that within the consortium, each state several states are doing different things. So some of the states that I alluded to, Massachusetts, New York, and others, have participated in the bulk purchase agreement, but it's incumbent on each state to develop its own policy. What I was trying to argue, and I know it's a little bit technical, is that some states are having exclusive agreements with one company in exchange for a deep discount. Now, that's important to control prices, but at the same time, I would argue that you can also expand access and still get a deep discount. Those two things shouldn't be mutually exclusive, and it's not in the best interest of all of our patients. But what should happen, I think, is a transparent conversation about how all of this plays out. What are the price points? What are the other states doing? And what are the exclusivity agreements that are on the table here in Rhode Island?
Are there any examples of that with other treatment regimens? I mean, where there's literally only going to be one drug? Because I mean, fluticasone versus Flonase. I mean, I can see that, but even then, there's
take an example
We're
like
literally one
inflammatory
choice.
bowel disease, patients
Yeah.
who need injectable drugs like Remicade, and there are cousin drugs of it like Humira that you see advertised, Cimzia and others. So you might have Crohn's disease or rheumatoid arthritis. That highest injectable level of drug is, a 10 to 20K a year medication. And there's a huge amount of maneuvering by the insurers and the PBMs to say, we're going to go all the way with Humira for this population. Dr. Epstein can get one of those other drugs for his patients if he really needs to, but we're going to bog him down with a couple of hours of paperwork, and I'm okay with that. Let me do a prior authorization 1 in 20 times, not 20 out of 20 times. So I think that's where, I'm a big proponent of bulk purchasing, because I think, if you tell me something's half the cost, that means I treat 2 patients. I won't spend less money. I'll treat more people.
Question?
And I think that goes back to this whole issue of the business model has to shift. And the only way for that business model to go from the high margin, low volume to the high volume, low margin is for us to break the ice. And that's today. We need to do that. We need to get people access to these medications.
Representative Fogarty?
Thank you again for your testimony. Very, very interesting. Now, one of the commercials they had for this Hep C medication, they talked about one of the gentlemen was saying about he was very careful about putting his razor away and where he leaves his razor. Is there a lot of family members who are catching it from other family members? I don't know if anybody really touched about that. We talked about pregnancy, and so that commercial just kind of had me a little concerned.
It's a very sad commercial. Yeah, it's just trying to enhance the stigma and fear about hepatitis C. I think it's a tragic second commercial about household transmission is essentially nil.
Okay.
We say theoretically because Hep C is transmitted by blood that contains Hep C. That if someone in the house shaves and uses a razor, that there could be a microscopic amount of blood and thereby Hep C on the razor, and another person shouldn't use that razor. And if theoretically someone's brushing teeth and there's a microscopic amount of blood on the toothbrush, there could be a little virus on there, or another person shouldn't use that. But we actually don't have documented transmission. It's really, when we rank transmission, it's blood transfusion, injection drugs, snorting, other kinds of things. this isn't even on the scale.
Okay, because I wanted to make that clear, because actually I used to be kind of in the healthcare industry. I actually was in pharmaceuticals and launched the Hep A and Hep B vaccines years ago, so very familiar with them. So it brings me to my next question regarding vaccines with the Hep C vaccine. Where would you see when this vaccine does come about? Again, how long do you think it is, and where would we vaccine?
In the last year, there have been a couple of nice vaccine breakthroughs, but you're still looking at a 3 to 5 year window before we're all taking the Hep C vaccine. By the time it comes, there won't be hepatitis C to get. If you mathematically model it,
Right.
this will go away. The way I used to lecture about this topic and say the way mumps went away and measles and rubella, except
Well, yes, yeah, well, that's another story,
there
yes.
it's coming back. But it can be gone.
Yeah, that was my question, because you were talking about that modeling, and if we had the Hep C vaccine, where would you, hopefully we'd get it, and hopefully we'll get a good bundling and get this price down that we can afford it. Again, ounce of prevention, pound of cure, I truly believe in that, obviously, with vaccines in the past. That's why I was going to ask, what would be the age bracket where you'd start? I know we get these kids early on with the Hep B right at birth, and, I think it was a 0-1-2 shot.
Discussion, because
Yeah.
if there's no Hep C, there's nothing to vaccinate.
Well, I hope you're right. I hope you're right.
I hope I'm
Hep C,
right.
I hope you're right. All right, thank you very much. Appreciate that.
Sorry, they won't fit. Thank you both very much for your testimony. The state of Rhode Island is very lucky to have healthcare policy and providers with so much passion about what they do. A quick question about, you made your point very well about, the pay me now or pay me later. It's much better to do this now rather than to get to a transplant situation when someone is sicker. But within the realm before that point, do you see a difference in efficacy of the new medications stratified within your staging or typing? Meaning, is there truly a benefit to very, very early versus later early? To make the argument for diagnosis, treat, rather than diagnosis, wait.
There was with the earlier drugs. Right now, the failures are going to be in the very sickest transplant patients, but those people are getting treated kind of pre and post transplant, and they're coming out without reinfected livers. So except for the stage 4 patients, full out cirrhotics, yellow, full of fluid, desperate, there isn't much change in efficacy on 1 through 3. So we can use that across the fibrosis
Just because the new
spectrum.
drugs are so potent.
They're so great.
Oh.
Thank you. Thank you, Mr. Chairman.
Thank you. Thank you very much. We appreciate your patience with us tonight and great testimony. Chairman Miller?
Yes? Stand up so we can...
I'm listening, I'm hearing, and I'm wondering, do you have a minute to hear the personal testimony of someone that has gone through the Hep C treatment and is cured? Do you have that moment with that help in terms of some of these questions
If
that's coming up?
there are any other questions before we get to this from representatives?
Okay.
And we have another doctor there.
They could be brief.
Yeah.
Is it possible?
If so there's 2 requests to add? Okay, why don't you both come up and we'll wrap it up with your input.
Thank you. You said 2 seconds.
You asked first, so you want to go first?
All right. Well, my name is Donald Daly. I've been a patient of Dr. Lynn Taylor over there for, I guess, at least since 2000. When I first went to Miriam Hospital, I was diagnosed HIV positive in 1987. About that same time, I think that I also was Hep C, but didn't know it exactly then until around 2000. It wasn't until November of this past year, I started in July, the Hep C treatment. And I know that Dr. Taylor, she went through hell trying to get me authorized so that I could take this. But she also, because of knowing how long I've been waiting for something to come down the pipe that wouldn't have a negative or adverse reaction with all the other medicines and all my other conditions, took a lot of patience to wait on my part, and it took a lot of patience for her to fight on her part to get me this drug. And I'm telling you, as sure as you're looking at me standing here today, Monday she gave me a call and said, Don, I'd like to give you the good news. Since November, you are cured of Hep C. Now, that was good news, but I took it kind of still lightly because I said, well, let me keep drawing some more blood draws. But you know what? I don't really have to even do that because I know and can feel inside. You know, these halls here are full of people's words and, you know, people's agendas and people's things, and that's all well and good. But until you hear from people that actually have to live it, you know, I ain't cured of HIV positive, but it's not showing in my blood because I've been taking one pill. I started off taking a cocktail with the HIV. Now it's down to one. With the Hep C, I had to take two. The Sovaldi from Gilead and Ribavirin. The Ribavirin had me going, I didn't know which way was up. But for 24 weeks I did that. And it took a lot out of me up here. You know what I mean? It took a lot out of me to keep making keeping my appointments. But I know this. I was up in my bedroom window that night. I live in Pawtucket. There's two flags. There's a flag of the United States of America, and there's a flag of the state of Rhode Island that says hope. And I'm here to just say to y'all, give hope a chance. You know what I mean? You got it within it. Give hope a chance with these people that are being diagnosed Hep C. I know that there are more people dying from Hep C today, right here, right now, than there are from HIV. You know?
Absolutely.
And if hope can get us in the boat and ahead of the storm that's coming, then by all means, if it's within your power, do it. That's how I get it. Thank you.
Now, that is kind of a perfect way for us to wrap up, so you want to jeopardize that, go right ahead.
I felt compelled to be here, and I feel compelled to just make a brief statement. My name is Steve Pelagian. I've been an addiction medicine doc for a long time. Started screening, making mandatory hepatitis C screening mandatory in 1999 at Kodak Behavioral Health Care. What I wanted to make a comment about is the financial. A lot of this is the concern is financial. The cost of treatment, having people wait until they're more sick. Well, on that balance sheet, on that financial balance sheet, there are cost savings. Some of the cost savings are not having to pay for, as you mentioned, comorbidities. And treating people early keeps people in the workforce also. So there's less disability, less out of work time. So there's other factors on that balance sheet more, besides just the cost of the medicine. Thank you very much.
Thank you.
Thank you.